Let's discuss cystic fibrosis. We will discuss about cystic fibrosis, genetics of cystic fibrosis, pathophysiology, diagnosis, complications of cystic fibrosis, and treatment of cystic fibrosis. First, we will discuss about genetics of cystic fibrosis. Cystic fibrosis is basically autosomal recessive disease. It is caused due to defect in CFTR gene on chromosome 7. Deletion of delta F508. It is most common lethal genetic disease in patients with European ancestry. Cystic fibrosis is most common and lethal genetic disease in Europe. Pathophysiology of cystic fibrosis. Cystic CFTR gene, it encodes ATP-gated chloride channel that secretes chloride in lungs and GI tract and reabsorb chloride in sweat. Delta 508 deletion leads to misfolded protein, and that because of this improper protein trafficking, protein absent from cell membrane, that leads to decreased chloride and H2O and bicarbonate secretion. Compensatory increased sodium reabsorption via epithelial sodium channels or ENAC. That leads to increased H2O reabsorption. Because of this, abnormally thick mucus secreted into lungs and GI tract. That leads to increased sodium reabsorption. More negative transepithelial potential difference. So it was pathophysiology of cystic fibrosis. So diagnosis of cystic fibrosis is due to sweat test. Cystic fibrosis is in, diagnosed by sweat test. Increased chloride concentration in pilocarpine induced sweat test. It can present with contraction alkalosis and hypokalemia. Due to ECF, sodium water losses via sweating and concomitant renal potassium hydrogen wasting. Increase immunoreactive trypsinogen newborn screening due to clogging of pancreatic duct. Complications of cystic fibrosis: recurrent pulmonary infections. These are main complications of cystic fibrosis. For example, Staph aureus, infancy and early childhood. Staph aureus causes complications in infancy and early childhood. P. aeruginosa, it causes in adulthood. Allergic bronchopulmonary aspergillosis or ABPA, chronic bronchitis and bronchiectasis. Reticulonodular pattern on CXR, opacification of sinuses, nasal polyps, nail clubbing, pancreatic insufficiency, malabsorption with steatorrhea, and fat-soluble vitamin deficiencies A, D, E, and K, progressing to endocrine dysfunction. Biliary cirrhosis, liver diseases, meconium ileus in newborns. These are all complications of cystic fibrosis. The main complications of cystic fibrosis are infertility in males and females. In males, absence of vas deferens, spermatogenesis may be affected in males, and subfertility in females because of amenorrhea and abnormally thick cervical mucus. So treatment now we will discuss about treatment of cystic fibrosis. So basically, cystic fibrosis treatment is multifactorial. So first we will do chest physiotherapy or we will use DNase or aerosolized Dornase alpha or DNase, not DNase, it is DNase. And hypertonic saline. Hypertonic saline is 7%. It is very useful treatment for cystic fibrosis, and it is used for Hypertonic saline is used for mucus clearance. Okay, so it is main treatment option for cystic fibrosis. So we also use azithromycin because it prevents acute exacerbations of cystic fibrosis. Azithromycin is also very important drug. Ibuprofen for anti-inflammatory effect. Ibuprofen is also very important for its treatment, and we use pancrelipase after eating for pancreatic enzyme replacement therapy for pancreatic insufficiency. CFTR modulators are very important, and these are very important for treatment of cystic fibrosis. They can be used alone or in combination. Efficacy varies by different genetic mutation. These are either potentiators, hold gate on CFTR, or channel open for chloride, like ivacaftor. Lumacaftor and tezacaftor. Ivacaftor, lumacaftor, and tezacaftor. These three are very important drugs for treatment of cystic fibrosis. So lumacaftor and tezacaftor, these help CFTR protein to form 3D shape. So it moves to the cell surface. So lumacaftor, tezacaftor, ivacaftor, these are main treatment option for cystic fibrosis.